am a professor of pediatrics. I'm one of the pediatric hematologist oncologists at UPMC Children's Hospital of Pittsburgh. I'm the director of our Pediatric Bone Marrow Failure program here, and I will today be talking to you about a comprehensive management approach to patients with bone marrow failure conditions. So first, just briefly, some objectives. First, I'm going to talk through some normal bone marrow function and structure briefly, as well as a broad definition of bone marrow failure. Then I'm going to get into not an extensive list, but some of the more common in a rare condition, bone marrow failure conditions, talking about some clinical findings, laboratory findings, diagnosis and management. And then toward the end of our talk, I'll talk about our current pediatric bone marrow failure program at Children's Hospital here, in conjunction with our bone marrow transplant program and our association with the North American Pediatric Aplastic Anemia Consortium. So no disclosures. So I want to start off with this slide to kind of just discuss the structure of the bone marrow. So the bone marrow is essentially the tissue compartment that's part of the inside of all of our bones in our body, and it's essentially what I like to call as the blood cell factory. It's where all types of blood cells are made, developed, and then sent off to other parts of the body. So you can see this is kind of like a cross-sectional cut through a bone showing the general structure of the bone marrow. So it's very vascular, it has lots of arteries and veins, and then it has the tissue structure to develop production of different blood components. So you can see here, they develop the red blood cells, the granulocytes, which are the white blood cell precursors, the megakaryocytes, which are the platelet precursors, as well as multiple other types of blood cells, including different blood and stem cells as well. So again, very broadly, bone marrow failure is defined as the failure of this bone marrow structure or system to adequately produce one or more of these different cell lines that I talked about. It can be either hypoplastic, where you don't have complete failure of production, but you have a significant decrease in activity, or aplastic, when you just have a complete failure of production of those cells. And it can be either inherited or acquired from different reasons. So just some general clinical findings from different aspects of bone marrow failure. So you can see either single cell lines down or all cell lines down, or pancytopenia essentially. For the single cell lines, there's those three main blood cells that I mentioned earlier that you can have low. So anemia is when you have low hemoglobin or the red blood cells. General findings you can see are fatigue, pallor, so paleness in the face, shortness of breath, pica, which is mostly associated with like an iron deficiency anemia, but can also be seen in general anemia, and increased heart rate. Leukopenia is low white blood cell count. So these kids can have abnormal or persistent infections, abscesses, either skin or other places, mouth sores, diarrhea, fatigue, you can see with this. And then thrombocytopenia, which is the low platelet count. Most commonly, so the platelets are the cells that help you stop bleeding, help you form clots. So you can see with low platelet counts or thrombocytopenia, you can see increased bruising, bleeding, or some of these characteristics called petechiae, which are little pinpoint skin lesions that look like a rash but aren't really. It's really kind of microvascular bleeding essentially. And then, like I said, you can have pancytopenia, which is involvement of all these, so you can have a variety of these clinical symptoms. So first I want to talk about some syndromes that typically involve a single cell line. Like I said, this won't be an extensive list, but I wanted to kind of hone it into some of the more common in a rare condition that some people may be more familiar with or not. So two that I want to talk about for those involved in red blood cells, mostly Diamond-Blackfan anemia and congenital dyserythropoietic anemia. So Diamond-Blackfan anemia is a condition that's most notably noticed in infancy. So you can see here that the majority percentage of these patients are either symptomatic or noted on laboratory findings by the age of 18 months, with about 10% of these kids at birth being severely anemic from that standpoint. Majority in the Caucasian population, but I've seen the wide gamut. It's inherited by multiple different ways that also really kind of varies on the mutation. One of the most notable genes is this RPS19 gene, but like I said, you can see lots of different variant inherited patterns and mutations. This, in addition to just the anemia aspect or the blood aspect, this condition has multiple other clinical features that you can see in varying degrees. So some patients can have a cleft lip or palate, can have micronaphia or small jaw, micro or macrocephaly, so small or large head, macroglossia is big tongue, wide fontanelle, you can have extremity changes or abnormalities, short stature, eye abnormalities, kidney abnormalities, genitourinary abnormalities, and heart defects. So it can kind of, not everyone has all these, and sometimes different patients have different combinations of these, essentially. The laboratory findings, like I mentioned, this mostly affects the red blood cells. So you see a low number of red blood cells, and the red blood cells that you tend to see typically are bigger than normal. And then you also see a decrease in what's called these reticulocytes, which are essentially the young red blood cells. So it's showing that the bone marrow is not producing enough red blood cells that it needs for its body. And this is a list of some of the other kind of other lab testing that we see during or with this condition. Different pathologic findings. So we can both look at the blood smear, which is just a peripheral blood draw, that we can look at the blood underneath the microscope, and you see these findings that I mentioned before. So you have a low number of white blood cell or red blood cells that are bigger than normal, and also a lower incidence of these young reticulocytes. And then also you can do a bone marrow evaluation. So what we do, you can take usually through the hip bone, which is one of the bigger sources of bone marrow, with the patient put to sleep by anesthesia. We take a needle and we go in there and take a sample of that bone marrow to essentially look at the factory to see if there's any clues of what's going on. And with Diamond-Blackfan anemia, you see a majority normal bone marrow, but there's abnormalities in the red blood cells or the erythroid precursors. So you can see here, again, you can have normal cellularity, normal other cell types, and but 90% of these patients have a low or absence of the erythroid or red blood cell precursors. Therapy for Diamond-Blackfan, two initial main therapies. One, first and foremost, since these kids can develop, start with very severe anemia, the most important thing to support them early on is to transfuse them with blood to make sure that they have enough of that red blood cell and oxygen carrying capacity to start off. So typically the first treatment is to transfuse these patients to make sure that they're safe moving forward. Next step typically involves some amount of corticosteroids. So steroid treatment has been shown to help really help increase blood counts in these patients. I listed here, which is a little busy that I can kind of skim through, that there's lots of varying responses that you can get to corticosteroids. The majority of these patients, up to 60%, can have a response, and then for a longer term, we're at some steroid dependence, but what we usually do is we start off high to get a really good response with the steroids, and then we wean it down to the lowest effective dose and spacing, so sometimes every other day, every couple days, to maintain a normal, healthy, or safe hemoglobin, essentially. So a majority of these patients can do that, but in that subset, there's a good amount of patients that actually can come off of steroids completely for one reason or another. And there are, as I want to mention here, a good amount of patients, 30 to 40%, that can actually have no response to steroids, which would be more concerning to look for in next steps. And speaking of next steps, if patients fail steroids, so like if they don't have a response or they had a really good response and then they lose their response and just are still having this severe anemia, the next standard is, I abbreviate this, but this is hematopoietic stem cell transplant. So a transplant essentially giving them a new marrow system that will produce red blood cells appropriately. And that has had pretty good success in general, as you can see, at least 75%. This data is a little bit old, so I think it's definitely a little bit more than that now, but it's definitely kind of a discussion throughout the process. Next, I just put one slide on here because this is rather rare, but I wanted to talk about briefly congenital dyserythropoietic anemia. Mainly, it's an inherited condition that affects, again, the production of normal red blood cells. So there's mainly 3 types of these, and you can see these listed here. And I just wanted to point out that treatment really varies between either being completely asymptomatic and not having any issues or needing transfusions, or patients that need more frequent transfusions or other interventions, or considering transplant from that standpoint. But I just wanted to kind of just point that out as just a general broad one. Moving forward to white blood cells, one of the main ones I want to talk about is severe congenital neutropenia, which also includes Shwachman syndrome. So SCN, again, rare, about 2 cases per 1 million people, and typically they have this ANC, or what's called an absolute neutrophil count. And a neutrophil is just a type of white blood cell that's usually less than 200. For the majority of infants, a normal count is 1,000, and then past about a year or so, a normal low count is 1,500. So with this ANC being less than 200, that's severely low, hence the name. These patients actually present with very frequent infections because, like I mentioned before, the white blood cells are the infection-fighting cells. So if you're not having those or they're not functioning as well, then you're at increased risk of infections earlier on, since these kids aren't producing them from the get-go. So they can present with lots of different ones, like infection of the umbilical stump, pneumonia, skin infections, sepsis, meningitis, and I mentioned some of the bugs here that are commonly seen infecting these patients. Historically, before we knew more about this, it was very severe and could cause death by age 2 just due to the overwhelming infections. This is a very busy slide, but I just wanted to mention that there are multiple different mutations that are associated with SCN. 2 of the main ones are the Elaine gene and the HAX1 gene, and they both produce proteins that are in the neutrophil that help keep the neutrophil healthy and alive. So when these are mutated and they're functioning abnormally, then the neutrophils die a lot earlier on before becoming their full form. So how do we diagnose this? Pretty straightforward. There are genetic testing panels for a lot of the more common genes, as well as just doing a bone marrow biopsy, like I mentioned earlier, for the other patients. And here you see just a very characteristic to where, again, the majority of everything else is normal, except for the precursors to those neutrophils or those white blood cells, to where it shows that they develop up to a certain point and they just stop and they don't make those mature neutrophils that work. Treatment for this, a good majority, over 90% of patients actually respond to what's called GCSF. So that's essentially it's a medication that's given by injection that is a neutrophil growth factor. So we help give the marrow a boost, and that the marrow then responds and is able to produce healthy neutrophils. The goal of this is not always to get to a normal A and C, but that would be nice. So I usually give a range, but here I put from 1,000 to 2,000. But the main goal is to make sure that we're minimizing infections or other symptoms that they may be having from their neutropenia. So we usually start at a pretty standard dose, and we adjust every 1 to 2 weeks because sometimes it takes some time for it to build up into the body, so we don't want to make changes too quickly. And then once we get a good response, we then again come back down to the lowest effective dose that we can adequately maintain a safe neutrophil count for these patients. Like I mentioned, it's important to follow the bone marrow in these kids. Typically, the initial one we like to, if possible and clinically safe, we'd like to get that first one before trying GCSF because that can change the structure of the bone marrow essentially, and would potentially muddy the waters in some of the diagnostic aspects. And then we usually, if possible, we recommend doing annual bone marrows because these kids, in addition to just having low neutrophil count, are also at risk of having development of other malignancies and other changes like that. And then for those people that potentially don't respond to GCSF or require really high doses or develop some of these malignancies, so like MDS or AML, or have poor prognosis genetics, are when we consider that you can transplant these patients as well. Moving on to platelets, so 2 quick ones. Congenital amegakaryocytic thrombocytopenia, so congenital, it's inherited. Amegakaryocytic, so they're without the megakaryocytes, which are the platelets precursors that I mentioned earlier, and thrombocytopenia, which just means low platelet count. So you see these kids early in life with really low platelet counts that can cause very severe bleeding. Most commonly, you see the thrombocytopenia within the first month, and then usually they're given this diagnosis once we're able to do a bone marrow when they're again safe and adequately able to undergo that procedure. Like I said, it can be very severe, and you can have some other physical anomalies with this too. This bone marrow evaluation will again show everything else mostly normal, but you don't see either any or very low amount of those megakaryocytes, which are those platelet precursors. There are some genetic mutations associated with this that we can test for too if there's concern. I did just want to mention to you that there's also an increased carrier frequency in the Ashkenazi Jewish population, but I've seen obviously a wide range of people with it too. So treatment is mostly supportive, so we can transfuse platelets to make sure that they're at a safe level and minimizing bleeding. And the only curative, because this is inherently in the bone marrow, is a bone marrow transplant. Some of these may progress to what's called severe aplastic anemia, which I'll talk about later, which is a pancytopenia. So they can progress for one reason or another to like having anemia as well as low white blood cell count too. And then I mentioned briefly here that future considerations are for any kind of genetic syndrome, potential gene therapy to as other future treatment, but nothing specific currently. Second is thrombocytopenia absent radii. So thrombocytopenia, low platelet count, absent radii. Radii are one of the 2 bones in the forearm. So these patients are pretty obviously seen on physical exam right from birth or even in utero, to where they're missing this one bone or this bone on both sides, and they have severe thrombocytopenia. They typically, and to keep note of before talking about Fanconi anemia later, they tend to have normal thumbs with this, but just have the missing radii from both sides. Like I said, mostly are diagnosed in utero or first day of life, and they can have very significant bleeding from this very low platelet count. And a lot of potential morbidity or even mortality, so deaths, can occur within this first year due to very bad hemorrhage. So it's very important to stay on top of these kids and make sure that we adequately have them at a safe platelet count from transfusions. The one interesting thing about TAR is that this thrombocytopenia actually is shown to improve with time, and sometimes by the year one or the first year of life, these patients' platelet counts can resolve back to normal by themselves, essentially. So the main thing is making sure that they are safe in that interim as they're improving on their own, essentially. However, there are a certain subpopulation that don't always improve or have a severely low for long period symptomatic to where a transplant is an option for those patients. And there's not really much benefit from corticosteroids or other interventions for these patients. Okay, jumping into pancytopenia. So this is all different cell lines. First is Fanconi anemia. It's kind of a misnomer that it's anemia, which you think of as like a low red blood cell count, but this includes all cell counts. It also has some very typical clinical features. So this is some pictures of, you can have short stature. You can have some abnormalities, like I mentioned before, to keep note for TAR that have normal thumbs. These kids tend to have abnormal thumbs, where they have these like dangling thumbs, or you can see these thumb abnormalities here. Tend to have smaller heads and what can be described as like a triangular face, if you can sort of see that. And this doesn't really project well, but you can have some different skin lesions as well throughout this, plus several other things as well. Like I mentioned, these typically progress to a pancytopenia, bone marrow failure, and usually starts with the thrombocytopenia, so low platelet counts in the first decade of life, and progress from there. You can see the bone marrow evaluation is usually pretty hypoplastic, so decreased cellularity, decreased structure, etc. Diagnosis can be made different ways. So there's a screening test that we call this chromosomal breakage, because Fanconi anemia is essentially a DNA or chromosome repair defect, to where these patients' DNA and chromosomes are more fragile than other people. So this chromosomal breakage testing, we expose the sample to one of these two different medications, or these two drugs, and we witness to see if there's normal or increased amount of chromosomal breakage under the microscope. And those with increased amounts are more suspicious for Fanconi anemia. From there, there's a lot of different genes that have been found throughout the studying of this syndrome that we can then do direct genetic testing. And these genes and Fanconi anemia is part of this caretaker gene disease that include ataxia telangiectasia, Bloom syndrome, xeroderma pigmentosa, hereditary non-polyposis colorectal cancer, and then the BRCA1 and BRCA2 breast and ovarian cancer genes as well. So therapy for this, there's different types of medicines called androgens, most notably oxmetholone, that have been shown to help with patients that have developed lower and symptomatic blood counts that you can use with corticosteroids as well. Transfusions as need be, that's always the quickest and most effective if you have a severely anemic, thrombocytopenic, or neutropenic patient. You can consider the G-CSF as like a neutrophil boost. But the only main curative treatment for the hematologic manifestations would be a transplant. And then in general, like I said, since it's a DNA repair defect, it's recommended to avoid DNA damaging agents and radiation. These patients are also at risk for developing other types of cancers, in addition to just like blood cancer, so leukemia, also because it's in genes that are in all tissues of the body, different other cancers as well that need to be surveilled throughout this patient's life. Next, briefly want to talk about Dyskeratosis Congenita, or DC. This is a group of what's called a telomere biology disorder. So briefly, the telomeres are what I like to say, the caps of the DNA sequence of the chromosomes. And as we age or just with time, those get shorter and shorter and shorter. There is an enzyme in our body called telomerase, which helps extend and lengthen these caps to essentially preserve the cap of the chromosomes, to where when you have syndromes like Dyskeratosis Congenita or similar, these usually affect the telomerase and make it less functioning, which then causes these caps to continually shorten and shorten and shorten over time, which then the shorter they get, the higher risk of the chromosomes become damaged, or the gene or the DNA to be damaged, essentially. So it's another similar DNA repair or DNA damage syndrome, essentially. So since, again, it affects the DNA, which is all over the body, it can have a variety of different clinical presentations. In the first decade of life, you tend to see this triad of leukoplakia, which is this whiteness on the tongue, dystrophic nails, so abnormal nail or nail abnormalities, and then some reticular or hyperpigmented reticular rashes from there. And then the second and third decade of life is when you can see the bone marrow failure develop. That's can be a wide variety, but usually starts as like a thrombocytopenia, so low platelet count, and then can progress to pancytopenia from there. And then, like I said, where it's affecting global multiple systems, you can have a wide variety of other presentations. So here is showing some a CT scan of the lungs, which shows some pulmonary fibrosis, so scarring of the lungs, as well as several other things mentioned here. So diagnosis, you can actually do a blood test that actually tests the lengths of those telomeres. And one of the big diagnoses for definitely just a general telomere biology disorder is when those lengths come back and they're less than the first percentile. So that's an abnormal test. We can also do a bone marrow evaluation that can show a variety of different findings, including, you can see the pancytopenia, depending on where these kids are. And then you can do genetic testing for a lot of those mutations that we know of. With these patients, mean age of developing bone marrow failure is usually around, so the second decade of life. These also have predisposition to other different cancers later in life, because again, it affects the DNA. And then a variety of treatments. So androgens have also been shown to be helpful in these patients, but have their own possible side effects and toxicities. Same thing with stem cell transplants is the only curative for the bone marrow failure parts, but can also be associated with toxicity. Avoiding DNA damage, damaging agents or radiation, and really only temporary changes with those growth factors that I mentioned before. I'm going to try and go a little bit faster because I'm getting toward the halfway point. I want to have some room for questions. Shwachman-Diamond Syndrome is another multi-system syndrome that mostly affects a lot of the GI aspects. So you have a lot of pancreatic issues and poor absorption issues from that standpoint, but you also have skeletal changes. And then from our standpoint, I'll show in a future slide, you have some blood changes as well. It's a variety of presenting symptoms or clinical features. And a lot of the diagnosis is really based around like a GI workup, so testing the pancreatic function as well as several other things from there too. And then specific testing, you can do testing for genetic testing for most notably this SBDS gene in approximately greater than 90% of these patients. So hematologic, this is an abnormality of the marrow structure. So it really is an abnormality in that first picture that I showed you of the support system that helped develop these, all the blood cells. You mostly see a neutropenia in these patients, but you also can progress to anemia and thrombocytopenia of these patients, with this pancytopenia being 20%. Older in life is AML, which is an acute myeloid leukemia later in life, as well as myelodysplastic or MDS, as well as the same thing. And overall, this incidence of the AML or the myelodysplasia is about 25%, and these tend to be pretty resistant to chemotherapy and looking more toward transplant or other options. So treatment, mainly pancreatic enzyme replacement, these growth factors that I talked about, so the GCSF, transplant for some of the more severe cases, although it's really a case-by-case scenario since these patients already have, or sometimes already have, poor organ function. So we want to make sure that we tailor our transplants as specific to the patient as possible to minimize other toxicities or other issues. And then monitoring before all this or throughout the treatment, whenever I have a patient, monitoring with bone marrow checks and lab checks, which I'll kind of talk a brief overview in a second. Aplastic anemia, finally, is, again, poorly named because you think anemia is just the red blood cells, but it really is for a pancytopenia syndrome. So the definition of severe aplastic anemia is when you have a decreased cellularity in the bone marrow, and also this being seen in the peripheral blood, so low neutrophil count, low platelet count, low reticulocyte count, and can kind of vary. It can be congenital, or it can inherited, or it can be acquired. So congenital, so some of the disorders that we listed before, plus a slew of other ones, and plus multiple that are already still being discovered and being noted to have genetic abnormalities. So I don't want to go through this whole list, but I just want to list there's a wide variety. And then acquired aplastic anemia is thought to be more of an autoimmune process, to where for one reason or other, either there's an infection or injury or insult that causes this inflammation and causes the immune system, and specifically the T cells of the immune system, to attack the blood cell precursors in the bone marrow, which then cause bone marrow failure, and then a slew of other changes from that standpoint. So treatment, the only curative, the gold standard is a transplant from a matched sibling donor. And typically, if these kids have a matched sibling donor and the clinical status allows, then that's first line, is to transplant the patient. There has been more data and discussion currently about possibly doing an unrelated matched donor, but there is still some working in the pediatric population from that standpoint. So if a transplant is not an option for the patient, then we do this immunosuppressive therapy, because like I said, it's most commonly, it's an autoimmune process. So you want to calm down the immune system by suppressing it. So that's with these medications right here, that usually a lot of these sometimes take some time to really get full effect. So that's why I say a duration of about 3 to 6 months, depending on the response. And then there's been more and more data on this medication called eltrombopag, which is initially known for like a platelet boosting agent, but has also shown improvement in some patients with severe aplastic anemia that's as considering options moving forward. So briefly, pancytopenia workup, like I talked to you about. If we have persistent pancytopenia, you want to rule out any other possible things, so like infections, drugs, medicines, and then kind of look for some of these signs and symptoms that I talked about for like bone marrow failure or these syndromes I mentioned. Refer to hematology, oncology, us, and then I listed just some general initial evaluations that we might check early on in this process. And then if we have a patient with bone marrow failure syndrome, monitoring really kind of varies. And this is a very just brief, broad overview of how I like to initially approach patients, but also taking it patient by patient to see what's best for them, their specific mutations or their specific clinical status, etc. But I usually start off, if possible, with at least a blood count, which is the CBC and diff, and a baseline bone marrow. And again, that can vary on either patient age or their specific syndrome variable. And then gear my workup or my monitoring depending on the urgency or the changing of those things. So if you have a patient that in general has a bone marrow failure syndrome that you know of, has stable blood counts, you check the bone marrow and it looks completely fine and normal, then I usually at least start off seeing these patients every 3 months, just like getting a feel for them. But you can check blood counts every 3 to 6 months, and then typically a marrow evaluation yearly, again, to try and catch things earlier rather than later that you might not see. And then here, if you have stable counts and the bone marrow shows maybe some mild changes, but not very like overtly concerning, then we can just check blood counts more frequently and consider checking a bone marrow sooner than the 1 year. But then if they're stable, you can reduce the frequency from there. If while you're monitoring, you start seeing these blood counts starting to go down, or you get a bone marrow that shows some increasing like changes or concerning changes, then again, I just check these more frequently and consider the full trend. Whereas if you're seeing them continue to trend in the wrong direction, that's when you start considering like either transplant or other treatments related to their specific condition. And typically, and I'll talk about our team in a second too, we work very closely with our transplant team. So a lot of the times our transplant team already know about these patients before we get to any urgent changes or anything like that. And then again, so these patients with severely low then are having symptoms from their cytopenias or develop any of these other concerning signs or things on their bone marrow, then that's when we would recommend definitely transplant versus other chemotherapies or treatments depending on what they show, essentially. So briefly, I just wanted to talk about our bone marrow failure program here at CHP. So first, I just wanted to say, list our current team members. So like I mentioned before, I'm the director. I'm the Pediatric Hematology Oncology physician representative. We also have a physician representative from the blood and marrow transplants and our Cellular Therapies department, so Dr. Jesse Barnum. We have a Pediatric Hematology Oncology nurse practitioner, Lindsay Wagner-Faith, a certified genetic counselor who's very integral in a lot of, like I mentioned, there's a lot of genetic testing that's required for these patients and kind of working with genetics from that standpoint. So we're very happy to have Christine Monroe as part of our group. And then we also have our nurse coordinator, Cheryl Ryden, that is also very integral to the group. And we are the only program in Western Pennsylvania that's focused solely on the diagnosis and the treatment of childhood bone marrow failure disorders. Our clinic's located in the main campus in Lawrenceville in our hematology oncology clinic. Typically Wednesday mornings are what our normal clinic is, but can be flexible depending on the urgency, since I do have other clinic days that if kids need to be seen sooner rather than later, we can make adjustments. And of note, during your kid's visit, they may see a combination of us. They may see me, they may see Lindsay, the nurse practitioner, and or Christine Monroe's genetic counseling throughout the process. And it really just depends on where they are in their phase of treatment, management, etc. Here's a list of several disorders that we see. Some of the ones I talked about, plus some of the other ones I unfortunately didn't have enough time to talk about throughout. Specifically, like I said, we work very closely with our bone marrow transplant team. And I was able to get some data from our clinical director from the bone marrow transplant team, Dr. Windrich. And he gave me these numbers that since January 1st, 2011 up until this month, we've had 44 total transplants for patients with bone marrow failure syndromes. Of these, 19 were severe aplastic anemia, and the rest were the wide gamut of some of the ones that we mentioned before. So MDS, Fanconi Anemia, SCN, Diamond-Blackfan, Dyskeratosis, other telomeropathies, and one unspecific. And overall, with all these patients, we have an excellent success rate of 95%. And then specifically excluding MDS, which sometimes is counted as like a precancerous or cancer condition. So not always directly a quote bone marrow failure syndrome. So if we take those out, looking at the more direct, some of the bone marrow failure syndromes that I mentioned before, the overall survival rate is actually 97%, which is very excellent. And then of note, Dr. Winters wanted me to point out, which I think is a key aspect of this. Like I mentioned, there's lots of toxicity associated with some transplant preparations, especially in these patients that have these multi-system affecting disorders, that besides the MDS who need a little bit stronger preparation, the majority of these patients actually got what's called a non-myeloablative or a reduced intensity conditioning regimen, which decreases the markedly decreases the rates of long-term complications like infertility, secondary malignancies, and other organ dysfunctions. Second to last, we are part of the North American Pediatric Aplastic Anemia Consortium, which is a national consortium that helps improve therapies for children with aplastic anemia, as well as inherited bone marrow failure syndromes and MDS as well. So I just included the website there for a little information. There are multiple different trials that are currently going through there, and some of them are open or in consideration for being open at CHP. Unfortunately, with the COVID pandemic, that has limited the availability of different just clinical trials being open or enrolled during this time. But as things pan out, this will hopefully be able to be open more and more. So we have a trial that was or is technically open at CHP, but could be is affected by the pandemic currently, of using that medication I mentioned earlier, eltrombopag, in patients with severe aplastic anemia. There's also an unrelated transplant trial, like I had mentioned before, as a possibility for getting good information for the effects for this with our pediatric population. Also have a quality of life study. And also, this isn't specifically a NAPAAC trial, but Dr. Shimomura is the principal investigator, and she's actually a member of an executive committee member of the NAPAAC consortium, where she has out of Boston Children's Hospital a pilot study of a medication called Metformin, which you might know more for like patients with diabetes, that has also been shown to help improve blood counts in patients with Fanconi Anemia. And then any other future novel clinical trials and therapies. Lastly, the referral process for our program. One of the main contact I would say would be our nurse coordinator, Cheryl Ryden, through our hematology oncology clinic. She'll be able to take the first contact, kind of get together the pertinent clinical information, and then send it out to our full team to figure out the best timing and the best way to schedule the appointment and kind of start on the workup from there. Families can self-refer, but during the if that is the case, then we will likely ask for contact information for your primary provider or referring provider to help essentially get more pertinent information to help with that triage process. And then again, it's a little repetitive here, but again, we just want to make sure that at first contact we have enough information earlier on to help get to your the question and the concern as quickly and efficiently as possible. All right, and with that, I'll just say thank you and see if there's any questions. I know they were going to send me some through this. I'll put questions here. Let's see. Let's trying to read some of these questions. So it says, for Fanconi anemia, is it better to remove alpha, beta, T, and B cell before transplant? Also, when donor is not related from registry. I'm having a little trouble kind of figuring out the exact question, but kind of leaning toward the transplant prep. That is hard for me to specifically answer, unfortunately, since I'm not a transplant physician, so I don't know the specifics in their preparative regimen. I do know that they tend to do a reduced intensity fludarabine-based prep for patients with Fanconi anemia, again, because of their risk of like DNA damaging from that standpoint. But sorry, I can't speak to as the alpha beta T and B cells transplant. Let me see. Do you have any ongoing studies at UPMC Children's on early detection or treatment of cancers in these inherited bone marrow failure syndromes, especially Fanconi anemia with SCC of the head and neck area can be really drastic. Actually, we don't have any ongoing studies at UPMC Children currently that I'm aware of. I do know one thing that I guess I did forget to mention in the broad spectrum of our hematology oncology department. We do have a specific cancer predisposition clinic, which is also run by one of our oncologists, our pediatric oncologists, as well as their own genetic counselor and geneticists as well. That, like I said, I don't think that there is a specific ongoing study or trial per se, but I do know that we have that as a very invaluable resource to us as well, that we, again, works out of our same clinic, and we are we work very closely with, to where if there are usually concerns for like those later developments or later concerns and kind of the monitoring from that aspect, to help with them, help make sure that we're not just focusing on the bone marrow failure part, which is part of my clinic, but also looking at those others down the line and trying for early detection from that standpoint. Let's see. Question is, do we know how eltrombopag acts on all three cell lines in aplastic anemia, but not only platelets? That's a really good question. I don't think the actual mechanism has been determined, honestly, because like I said, this eltrombopag is a platelet boosting agent that's usually used with certain platelet disorders or etc. But it has been found, and that's why there's these clinical trials and kind of more being found that that it affects mostly the platelets, but it also has some cross reactivity in the red blood cell and the white blood cell precursors. So it's actually shown some important improvements in all those cell lines from that standpoint. Let's see. And then the last question says, is metformin also for the Fanconi anemia subtype C? I'd have to look back at Dr. Shimamura's specific eligibility for that. I can't remember if the exclusion criteria specifically had the different mutations, because I know things have been changing throughout. I think it is still possible for subtype C, but don't quote me 100%. I think mostly the metformin is used as kind of an aldehyde or an oxidative scavenger-ish that has been shown to help with blood counts from that standpoint. But I don't know the specific for that subtype. I'm sorry. All right, scroll down and see if there's anything else. I think that's all. I still have, oh, maybe more? No, nothing else. We still have 10 more minutes too. I'd be more than happy to wait if there's any other questions that come through. I can also check, because I know that they're sending them through here to see if there's any other potential questions or concerns. But again, I do just kind of want to say in general that if there's any questions either from you as the parent, the patient, the physician, we are more than happy to help field calls, field questions, or specifically referrals too. We take referrals from all over the state, or as like I said, since we're the only main center here in Western Pennsylvania, so we kind of have a broad range, or broad net, I guess. So we're always more than willing to discuss any patient further. Yes?
Did you get any additional questions? You sent some more, but I don't know.
I don't see any additional. The last one is the Metformin for subtype C.
Somebody had asked about if they live somewhere outside of Pittsburgh, if they can come, like if you do consultations to help the managing physician.
Okay.
In an out, like a
so,
different setting.
Okay, so I was told that I think someone asked if you lived outside of Pittsburgh, what the process is from that standpoint. And I think there's a couple different ways. One, I think that you can ask your primary care physician, and the primary care physician can just call us through our hematology oncology clinic, and they'll be able to be directed to Cheryl Ryden, like I said, who's our nurse coordinator, and then she can help kind of arrange from there, either talking to us to figure out scheduling or working on checking labs or other reporting from there. So, and then we can communicate with you the best time and way for you to come see us for an in-person visit at Pittsburgh. There are sometimes, especially trying to think through, like with the COVID pandemic, et cetera, our hospital is set up for telemedicine too, and it could be possible if we got labs, we could consider doing an initial or one of the like a telemedicine discussion. It's usually harder for new patients because I like to kind of sit down and do a full physical exam and everything like that with the patient. But it really depends on the how far away you are or how you are able to do it. But we are definitely willing and able to work with you to figure out the best option of being evaluated. But I would say, again, and to kind of take it so you don't have to call into our clinic, and if we ask for certain medical things you may or may not know, we wouldn't want to have to put that burden on you. So I would say to have your primary care physician contact us, and we can help arrange from there. All right, let's see. There's a question here. Any supplements or vitamins to take before SCT? So I'm assuming stem cell transplant. None specifically that are known or really have shown any help from that standpoint. And I would honestly, in general, for any like supplements or vitamins, one of my biggest approaches with any of my patients, either my oncology patients or hematology patients, you can always mention it to either our transplant physicians or any one of your doctors. If it won't cause any harm, I'm fine with it. But a lot of the times, some of these supplements or vitamins can actually have significant interactions with some of the medicines that we're going to be giving for either the transplants or for other treatments, to where it could hinder the actual treatment that we were doing. So I usually request that my patients and families tell me before starting any other kind of vitamin or supplement, so then we can run it by our pharmacist to make sure that it's not going to have any negative effects on the patient or on the treatment delivery for what we have planned. So that would be the same for transplant as well. Is there anything else? I can see if I can wait to hear from the rest of the people helping. But yes, and I think I may have forgotten to put the phone number to our hematology oncology clinic on here, but it's definitely on our website. The chp.edu website can definitely be found from there. Oh, let's see. Oh man, a couple came through. Let's see. What is your approach to bone marrow failure patients who require frequent transfusions when transplant is not an immediate option? That's a good question. So that really varies on the type of bone marrow failure syndrome, if it's either a syndrome or, again, if it's acquired aplastic anemia, et cetera. My biggest approach, like I said, that's the biggest way to make sure that these patients are safe and not getting to the severely low option or severely low levels that can cause significant issues from that standpoint. So depending on where the patient is or et cetera, like I check very frequent labs, either through our hospital or can check local labs and things like that. I check a lot more frequently earlier on, so I can get kind of a sense of these patients' trends, specifically if they're requiring frequent transfusions, because I want to be able to transfuse a patient, but then see kind of their trend after their transfusion to see how quickly they're going down, and trying to estimate as closely or as far out as I can check labs, essentially, and really monitor for that. Other options, again, if it's a patient that we think is an acquired aplastic anemia that could benefit from the immunosuppressive therapy that I mentioned before, I think that's an option too, with also checking frequently the labs to see that trend, to make sure that we're not getting too low too quick. I'm very cautious earlier on, especially if I'm just meeting the patient or just or just learning about this patient, because every patient is different, and their lab trends and their severity of their anemias, or even how severely they're affected by certain levels of anemia or thrombocytopenia. So I err on the side of checking labs very frequently earlier on, and then trying to space out as needed. Let's see. Sorry, I don't think I can be unmuted, but you can. What's this? Oh, I just got a comment from one of our transplant physicians, Dr. Barnum, answering the question from earlier. So thank you, Jesse. So she said, you can, let's see, we do perform what's called ex vivo T cell depletion, along with ATG, which is one of the immunosuppressive therapies that we mentioned, to decrease the risk of GVHD. And then, yeah, as we mentioned too, we have that reduced intensity conditioning that especially has, again, lower incidences of different side effects and things like that I mentioned earlier. So thank you, Jesse. I appreciate that. Let's see. Having trouble kind of interpreting this one. There are a lot of transplant questions. So Jesse, it says after transplant NAD booster, nicotinamide riboside B3 question mark. Is it okay? I don't know. It looks like Kelly, if you can you clarify your question a little bit more? I'm not quite following exactly. Oh, we're done? Okay. So sorry again, you can reach out to us, especially Kelly too, if you have a clarification, reach out to me and or Jesse to see from that standpoint. But it looks like we are coming down to the last minute of the webinar, so I think it's going to be cut off soon. So again, I just want to thank you all for attending this, and we're happy to help in any way possible if you just reach out. So thank you.